Good evening everyone. I am going to talk on BRAF mutation in non-small cell lung cancer. So you know that MAPK pathway is an important pathway involved in the lung cancer development, and in BRAF mutation circumstances, the receptors on cell membrane get activated, which phosphorylates the downstream signal gene, that is ROS, then which again in turn activates RAF gene. So there are three isoforms of RAF, A, B and CRAF. Among that, BRAF has high kinase activity and also high affinity to binding to MEK1 and MEK2 site. So upon BRAF activation, which in turn activates MEK, then MEK activates ERK gene. So phosphorylation of the ERK gene translocates into the nucleus and phosphorylates the transcription factors, results in the cellular proliferation and growth. Hence, MAPK pathway inhibition with the BRAF inhibitor shown clinical activity in non-small cell lung cancer trials also. So, incidence of BRAF mutation in non-small cell lung cancer is less common compared to melanoma or thyroid cancers. It is about 1 to 5% in non-small cell lung cancers. So, coming to the BRAF diagnostic technique, the most preferred method is NGS because it has high sensitivity and specificity, and also it allows simultaneous analysis of other actionable driver mutations. Coming to the BRAF mutations, there are about more than 300 mutations have been identified. Among that, BRAF V600E mutation is the commonest type. It accounts for 50% in NSCLC, and it is a missense mutation where valine is replaced by glutamate in codon 600 position in exon 15, and so majority of the BRAF inhibitors showed response to BRAF V600E mutations positive NSCLC. So based on the kinase activity, the BRAF mutations are classified into three types. Type 1 is a classical one, so where high kinase activity have been seen, and the most common mutation is BRAF V600E, and other less common mutations are V600K, V600D and V600R. And other types are type 2 and type 3 are mild to moderate kinase activity. It's also called non-V600 mutations. And important thing is the response to BRAF inhibitor in type 2 and type 3 are unknown. Some of the clinical features associated with V600E versus non-V600E. V600E mutations are associated with non-smokers, younger populations, and more commonly seen in females. Whereas non-V600E mutations are commonly associated with smokers, elderly age group, and there was no distribution between the males and females. And the response to BRAF inhibitors are very good in V600E mutation positive NSCLC patients, whereas response to BRAF inhibitor in non-V600E mutations are unknown. So dabrafenib and trametinib combination therapy is the only therapy approved in advanced non-small cell lung cancer in patients with BRAF V600E mutation positive. So with the usage of single agent BRAF inhibitor, that is the dabrafenib, showed early drug resistance and also higher hyperproliferative cutaneous adverse events. That is mainly because of the paradoxical activation of the MAPK pathway. Hence, the addition of MEK inhibitor, that is the trametinib to the dabrafenib, showed delayed in the drug resistance and also fewer hyperproliferative cutaneous events. So the most common mechanisms of drug resistance related to combination therapy are mainly MEK1 mutation, BRAF amplification, NRAS mutation, and also COT overexpression, and also sometimes activation of the alternative pathway like PA3K. So to conclude my talk, BRAF mutation is less common in non-small cell lung cancer compared to melanoma. Even NCCN and ESMO guidelines also recommended routine BRAF testing in all patients with advanced non-small cell lung cancers. Dabrafenib with trametinib, that is BRAF with MEK inhibitor combination therapy, more effective in BRAF V600 mutation positive advanced non-small cell lung cancer regardless of the prior therapy. And BRAF inhibitors in non-V600 mutations are unknown. Thank you.